All right, welcome back. So we're going to take what we learned from the first screencast and start to dive a little bit deeper into the specific measurements that we'll get from a cardiopulmonary exercise test and how those measurements can actually inform clinical decision making as well as exercise programming. We ended with our last screencast talking about the measurements that we get, including VO2, carbon dioxide output or VCO2, respiratory exchange ratio, which is that indicator of maximal effort, anaerobic threshold, and then also our heart rate, electrocardiogram data, blood pressure, our O2 pulse, which is an indication of or an estimation of stroke volume. And as a refresher, maximal oxygen uptake, or VO2 max, is going to be the maximal oxygen uptake that our body has to deliver and extract oxygen to our muscles in order to satisfy our metabolic demands of vigorous exercise. VO2 is going to increase linearly with work rate up until a maximal effort, where it will then start to plateau. So that's one way that we actually can see or determine that someone is at a true max effort, is that we start to see VO2 plateau. Even after we increase workload a little bit more, we'll still see that plateau. And again, as a refresher, thinking about the Fick equation, VO2 max can actually be computed from both that central and peripheral component, the central being cardiac output and the peripheral being our AVO2 difference. And it's influenced by our oxygen carrying capacity of the blood, so our hemoglobin, our arterial oxygen saturation, and those dissociation curve shifts. Specifically, how easy our body or how able our body is to drop off oxygen. And if you think about it, this is sort of where we get into biochemistry. So our hemoglobin wants to hold on to oxygen. And there are certain things that shift our curve, meaning when we shift in a certain way, hemoglobin drops off oxygen more readily. And those shifts include exercise. So when we exercise, body temperature increases, we're actually going to see a shift in our dissociation curve where hemoglobin will drop off oxygen more readily to the body for use. It's also influenced by our cardiac function. We talked in the last lecture about cardiac dysfunction and actually how, if we have a decrease in our strength of contraction, we're going to have a decrease in our stroke volume and therefore a decline in VO2 max. Redistribution of peripheral blood flow, extraction by the tissues, so things like capillary density, mitochondrial density and function. And both of those things we actually can improve through exercise training. So research has shown that exercise training will increase capillary density and can increase mitochondrial density, helping with extraction. Another thing to consider when we're looking at the measurements is, okay, now we have this measure of VO2 max, for instance. What does that mean? How do I compare to others of similar sex or age? And so there are reference data or normative data out there that we can look at and compare our age group and our sex. Is our VO2 max similar to that? Where do we fall? And in this graph here, what you're seeing, or table here, what you're seeing is that the 90th percentile is going to be the most fit, and the 10th percentile being the least fit. And one thing that we've, in research, a lot of times have said is we have this threshold, right? So when someone is at a VO2 max of less than or equal to 17.5 mLs per kg per minute, we think of them as deconditioned, have higher risk of disease. But while that might be true, what about a 20 to 29-year-old with a VO2 max of 19.3, so in the bottom 10 percentile. That probably indicates that they're on track to be at less than 17.5 with age, right? And so if we can intervene earlier, that would be really helpful to know what is the risk, what is that risk at an earlier age group. So this normative data is really helpful, and we also start to see a lot of clinicians and researchers kind of honing in on, what is the measurement at different age groups that we should be concerned about, not just a specific number, because we know that VO2 is influenced by age. And you can find this normative data for VO2, for maximal blood pressure, for maximal ventilation, all the measures that we're really interested in from an exercise test, what's normal, what's abnormal, and what might actually indicate potential disease. Anaerobic threshold is one that a lot of athletes are really interested in, but it's really important for the clinical world too, because if we prescribe exercise, or let's say someone's VO2 is 4 mets, which is really common in heart failure patients, and then we have them out and about doing their activities of daily living, which could come in around 2.5, 3 mets, or at their anaerobic threshold, they're going to be living with that feeling that maybe you're hitting when you're doing mile repeats or 400s on a track, right? Hard work. And that's not a great feeling if you're having lactate buildup and all the hydrogen ions changing your pH. So anaerobic threshold is something to consider clinically too. Specifically, anaerobic threshold is an estimate of the onset of metabolic acidosis caused by the increased rate of arterial lactate production during exercise. So it's also known as our lactate threshold. And when we build up lactate, our body is really good at buffering lactate. So we're always producing lactate in our body, but it's usually in this really nice balance of we create it, we buffer it, and it's cleared, right? And so we don't feel the muscle soreness and pain that we do when we're exercising above our anaerobic threshold, right? At a point, we are unable to keep up with that buffering process. And so as a result, the different chemical reactions in the body that are breaking down lactate, what we see is an increase in hydrogen ions. And those hydrogen ions are changing our pH of the muscle. And as a result, we're feeling sore. We're no longer in homeostasis. And anaerobic threshold is commonly referenced to our VO2 max. And so, a lot of people will say my, anaerobic threshold's around 65% of my VO2 max. And for normal, healthy adults that are sedentary, somewhere around 60, 65 is quite normal, maybe even a little bit lower. But someone who is an athlete, we actually do see a shift in your anaerobic threshold where your body's just a lot better at getting rid of and clearing that lactate. And as a result, you shift your anaerobic threshold up a little bit. And so we might even see this at 75%, 80% of your VO2 max. And one of the things we also pay attention to from the exercise testing data is our ventilatory threshold. This occurs as a result of the metabolic acidosis. And so what will happen is many people use anaerobic threshold, lactate threshold, ventilatory threshold interchangeably, but really the ventilatory threshold is different. Ventilatory threshold is going to happen after the anaerobic threshold, because as you are buffering and getting rid of the byproducts like carbon dioxide, you're exhaling more, right? You're trying to get rid of it. And so as a result, that change in your ventilation pattern is happening as a result of the acidosis. So the anaerobic threshold, you've reached anaerobic threshold already. So immediately after, you're starting to experience the ventilatory threshold. And like I said, a little bit lower than that 60%. So 40 to 60% is usually what we see for deconditioned or diseased individuals, and much higher for athletic training, people that are going through athletic training. The respiratory exchange ratio, this is one that on your testing, you probably want to pay attention to every minute, because it does give a good indication of how close someone is to their maximal effort. And respiratory exchange ratio can actually be calculated as your carbon dioxide output over your oxygen consumption. And it actually reflects in resting states our respiratory quotient. And as you can see from this chart here, we have at rest somewhere actually around a like 0.8, 0.85 for our respiratory exchange ratio. And that actually reflects a mixed diet. So this specifically, this respiratory exchange ratio is going to be influenced by nutrition. So if you're only consuming carbohydrates, you probably are starting a little bit higher. Versus if you have a mixed diet of carbohydrates, fats, and protein, you probably are starting somewhere in the 0.8 to 0.85. As you start exercising though, and it's a low intensity exercise, let's say, you're going to be relying more on fats to fuel. And so a RER of 0.71 is going to indicate that you're primarily, as you can see in this table, 100% here, using fat as your fuel source. And that's really normal. Low intensity exercise, we rely on fat. High intensity exercise, where we're getting close to our maximal effort, RER1, we now are relying predominantly on carbohydrates. And as you can see in this table, 100% on carbohydrates. And I mentioned earlier in the previous lecture that your respiratory exchange ratio can be 1.1, 1.2, 1.3. We've seen it even higher than that in some folks. And that extra is coming from really just the breathing out more. So that hyperventilation that's occurring at the end of exercise. That's what's driving up the respiratory exchange ratio above 1.0. Okay, ventilation is one that we look at as well and can also give us, just like ventilatory threshold, an indication of where we're at with the exercise. Ventilation increases with exercise to help arterial blood regulate gases and acid-base status. Minute ventilation, so just expressed as VE on our exercise testing in liters per minute, is increased by both our tidal volume and our breathing frequency. In normal, healthy, active adults, we see that maximal ventilation can be somewhere around 150 to 200 liters per minute, which is also helping to drive up oxygen consumption, because if we're breathing more, we're bringing in more oxygen that can then be carried in the blood. What we see is up to about 70 to 80% of peak exercise, ventilation is going to be increased by both that tidal volume, that depth of breathing, as well as our breathing frequency. And afterwards, breathing frequency is primarily responsible for the additional increases in ventilation. What's really, really interesting is that you probably are not counting how many times that you're breathing during rest or exercise. And there are points, as we can all admit, during exercise where you start to notice you're breathing, like, wow, I'm breathing really heavily, right? But even at submaximal levels, you probably aren't noticing your breath that much. And you're definitely not thinking about it every time you're just sitting in class, right? But usually this could be around 12 breaths per minute, right? And this can go all the way up to maybe 35, even higher breaths per minute with exercise. And if you think about like that many breaths for your breathing frequency plus the depth of breath, like you're getting a lot out. Now, think about on the clinical side of things then. If we know that increasing our ventilation is important to bring that oxygen in for our muscles, but we have someone with COPD that has a hard time bringing oxygen in, right? Obstructive disease, they're not going to have a high VO2. They're not bringing in the oxygen that they need to be able to carry out that work. And they also have a really hard time. So the depth of breathing, and then just, it's very, it's a high labor process for them, breathing, both on the tidal volume and breathing frequency. One of the measures that I am really into right now is our ventilatory efficiency. And so this is our ventilation over our carbon dioxide output. So how many times do we have to breathe to kind of like get back to normal with the amount of carbon dioxide in our body, right? We're producing all this carbon dioxide. We don't want to keep it in our body. So if we have good ventilatory efficiency, every time we're exhaling, we're getting a good amount of carbon dioxide out, is a good way to think of this. But if you have poor ventilatory efficiency, you're breathing and there's this high amount of carbon dioxide still left in your body. Okay. So when the ventilatory efficiency ratio, so VE over VCO2 slope, is greater than or equal to 34, there is a higher risk of cardiac mortality in these folks by 23.9. So the hazard ratio is 23.9 here. That means they have a 23.9% or fold higher risk of 1-year cardiac mortality than if it's lower than 34. Cardiac hospitalization, 4.1 hazard ratio, and cardiac hospitalization with both our VE/VCO2 slope plus a VO2 less than or equal to 14, 4.3 for our hazard ratio. So all of that information is then used by doctors. And what they see is if we're thinking about transplant and operation risk and, looking at the transplant list, there's actually criteria that you have to meet in order for cardiac transplant. Okay, so for 1-year cardiac mortality with the VE/VCO2 slope less than 34, they're low risk. So maintain medical management, assess and alter exercise habits as appropriate. These individuals are going to have higher survival rate and less complications with surgery. Greater than or equal to 34, increased risk. So assess present medical management and attempt to optimize, assess and alter exercise habits as appropriate. And potentially there needs to be other interventions that we're using. So things like maybe oxygen available for these people. Maybe there's like thinking about devices as well. And this is where the doctors come in and they think, okay, so we're at high risk. We have the risk of surgery, but do the benefits outweigh the risks? And they're looking at this data to really make that decision pathway. Heart rate response, this is probably one you're really familiar with, even in your own exercise training. Heart rate is going to increase linearly with work rate and VO2 up to heart rate max, and then we see a plateau. The initial increases in heart rate are going to be due to decreases in parasympathetic activity. So this is thought to be vagal withdrawal. And that happens up until about 100 to 110 beats per minute. So during rest, you are under parasympathetic activity and your heart rate is brought down. That withdrawal then brings your heart rate up, and up until about 100 beats per minute, that is what is primarily driving that increase in heart rate. Afterwards, it's primarily driven by the increased sympathetic activity, which is happening simultaneously, but which one is predominantly causing the increase changes based off of where your heart rate's at. Achievement of age predicted maximal heart rate from different equations. So we have the Fox equation, 220 minus your age, which is a really common one because it's so simple, although definitely flawed. And then there's also the Tanaka equation, a little bit more things to remember in that equation, a little less standard error, but still error. But that a lot of times is used as a reflection of maximal effort. And we know that there's an issue there because let's say I can just give you an example. When I was 25, I had an exercise test done and they came back with my max heart rate being 180. Well, that would be a max. If I use 220 minus my age, my max heart rate should be 195, right? And I was at 180, 15 beats lower than that. And there is this 10 to 15 beat per minute range error that we see both ways. Now, the issue there is that if you were to prescribe me exercise based off of the age predicted max heart rate of 195, that would be really challenging for me to meet. Actually, I wouldn't meet it because my heart rate max is going to plateau, right? Even if you prescribe 90%, I'd be at max or not able to reach it. So those are just some things to consider when using age-predicted max heart rate in exercise prescription. And chronotropic incompetence is the inability of the heart to regulate its rate appropriately in response to stress. And so what we see with these individuals is that there's a failure to increase rate proportionate to the increased activity or demand. And this can look like failure to achieve 80% of age-predicted max heart rate when we're not using an electrocardiogram, a delay in achieving age-predicted max heart rate, inadequate submaximal recovery heart rate, and we'll talk about recovery heart rate in a minute here. But if your heart rate is really delayed and like it's staying sort of close to rest, even though workload is increasing, so there's not that linear relationship, at a point we would call that chronotropic incompetence. And then rate instability during exercise. So we're not in steady state, it's really jumping all over the place. And you might have this happen from one stage to another, but if it's quite significant changes that we're seeing, and really not keeping up with demand is the key component here. It's really common in patients with cardiovascular disease, especially heart failure, as well as different arrhythmias like atrial fibrillation. And as a result, it's going to produce exercise intolerance. We're not going to feel good exercising at different levels if we can't keep up with the demands. Our body's going to reach that lactate threshold earlier, and we're going to feel soreness, out of breath, and the symptoms that are associated with exercise intolerance. And then people are going to avoid exercise, right? So it's a vicious cycle. Here are just some examples of what we see with chronotropic incompetence. So submaximal peak heart rate in the control would be a normal, healthy individual, and the individual with CI would be the red line here. And you're seeing it's lower at submaximal peak heart rate, so not meeting demands. There's a delayed heart rate response, so demands are happening and we need that oxygen, but our heart rate's not keeping up until later, so we're already starting to accumulate way too many byproducts. And not produce the ATP we need. Heart rate instability, so you're seeing this more wavy line with large changes and not steady state. And then inadequate heart rate recovery, our heart rate is staying up, doesn't get as high as we need it to meet demands, potentially similar, like when we're compared to the control, but then also it stays higher later. And heart rate recovery is something that actually is associated with prognosis. So poor heart rate recovery is going to be a risk factor for more complications, as well as cardiac mortality being one of those complications. So here we are, heart rate recovery. This is why during the exercise testing that you guys will perform, I want you to continue to monitor heart rate, blood pressure after exercise. We want to see a nice drop in heart rate. So 1 minute after exercise has stopped, we want the maximum heart rate to recover by 12 beats per minute. So we want it to go back down towards rest by at least 12 beats per minute. If it is less than 12, that's abnormal response. If it's less than 6, that's actually a threshold in heart failure scoring system. Does not mean you have heart failure. Other things could be going on. But putting that into the algorithm and the scoring system where we kind of say, yeah, we should really be looking into this more. 2-minute recovery, maximum heart rate, we want to recover by 22 beats per minute or more. So wherever we were, we wanted to come back down towards rest by 22 beats per minute. Again, these are associated with prognosis of disease and an important indicator of risk. O2 pulse is defined as the ratio of oxygen consumption to heart rate and expresses the volume of oxygen ejected from the ventricles with each cardiac contraction. We do see with exercise a curvilinear increase, similar to what we see with stroke volume. So it increases to a point and then we'll start to plateau, which is what we see with stroke volume as well. Usually that's around somewhere like 60-65% of our max, we'll start to see that like heart rate's really what's going to be what takes over there. A value greater than or equal to 85% of predicted is going to be good for survival and prognosis. And when we have a blunted response or a decline, it might even suggest ventricular failure. So oxygen pulse is used, again, with a lot of cardiac patients. Blood pressure is going to be a measure that we take at least once per stage during exercise. That's the goal. And what we want to see is that systolic blood pressure goes up about 10 millimeters of mercury per MET. Again, one MET is an indication of intensity if you have not learned about METs. And one MET is equal to 3.5 mLs per kg per minute. So every increase in intensity by 3.5 mLs per kg per minute, that is going to be what we should see an increase of about 10 millimeters of mercury in systolic blood pressure. Now, there is definitely differences in that depending on the stage you're in and things like if it was low intensity to moderate intensity or moderate to high intensity. There's some, you might catch up a little bit, but over the test, that's kind of what we see from start to finish, an average of about 10 millimeters of mercury per MET. With diastolic blood pressure, we want no change or even a slight drop. That's the normal response. When we see a drop or excessive rise in systolic blood pressure, more than this 10 millimeters of mercury, and getting really, really high, it could be an indication to stop the test. And actually ACSM notes that over 210 millimeters mercury is a contraindication to exercise testing. So we want to just be mindful of that and how high we're getting with the test. Whereas a blunted or exaggerated peak systolic blood pressure, that's also not good. It's actually associated with increased risk of cardiovascular disease and mortality in adults. And a blunted response would be at max effort, systolic blood pressure less than 140. An exaggerated response, as I mentioned, ACSM points out the 210, but actually there's been research that has, and it's sort of our more classic model, is 210 for men and 190 for women. Remember, I was showing you the normative data that's out there, and I think actually on this next slide, yeah, this normative data here, this is blood pressure normative data, and new research is evolving, thinking about the blunted response being the 10th percentile for your age group, an exaggerated response being the 90th percentile for age group, and how that actually, these specific numbers, age-specific numbers, are more in line or accurate reflection of risk. And so learning about heart rate, learning about blood pressure, we have what's called our rate pressure product. And the rate pressure product is computed as heart rate in beats per minute times our systolic blood pressure in millimeters of mercury. So that top number, right? And at rest, normal, healthy individual, probably going to be around 10,000 or less. Higher risk, so individuals that have above 10,000, they're going to be at higher risk for cardiovascular disease. And, we're getting blood pressure at every stage, we're getting heart rate every minute. So this measurement can be something that we actually calculate with every stage of exercise. And that's a really good thing, because when we start to see with patients, whether you're seeing them in clinic or they're a heart patient, symptoms like ischemia, or might be suggestive of ischemia, like angina, dizziness, shortness of breath, we actually have that data, right? We have, okay, symptoms are occurring when the heart rate is this and the blood pressure is this. But every day someone's going to come and their heart rate's going to be different than it was at rest. It's going to be different at a submaximal workload, right? Than it was the day before. Blood pressure might change slightly too, depending on, we know blood pressure is influenced by sleep and stress and what we eat, how much fluid we've had, right? So those things shift a little bit. But let's say one day our heart rate was elevated slightly and our blood pressure came in a little bit lower, and our rate pressure product calculated out to be 12,000. Well, then the next day our heart rate was a little lower and our blood pressure was higher. Well, guess what? It can still equal 12,000 and we can still experience those symptoms at that status, right? So this information is really helpful, but only when we're actually assessing heart rate and blood pressure in our patient population. And we are doing that in cardiac patients where this would be something where we see high risk. The other thing we use this for is with exercise prescription. If I'm seeing angina and these symptoms that I don't want my patient to experience, I'm going to write an exercise program that's at least 10% below the rate pressure product. Or potentially I use heart rate, like 10 beats per minute below this heart rate and 10 millimeters of mercury below the systolic blood pressure. Whatever is protocol for the center, but all that to say, it's going to be below the rate pressure product. So we keep people out of the danger zone. So let's just kind of go through this case study and do a little Q&A. So we have Clara here. She's a 60-year-old patient and begins to experience symptoms of angina and has 2 millimeters of ST depression on her electrocardiogram and lead 2 at stage 2 of the Bruce protocol. And stage 2 is 2.5 miles per hour, 12% grade. Her heart rate at this time was 130 beats per minute, and her blood pressure is 158/78. How would you use this information to guide her exercise program? So I'm thinking about a PT clinic and this patient comes in and maybe you're doing some testing and you run the Bruce protocol and they have angina. Well, the first question is like, do you have a cardiologist, right? Like, I'm going to refer you out. But let's assume, yes, that they do. And the cardiologist ordered this test, gives the green light for exercise. Now, what do you do? So now it's a different situation, right? Now they're coming to you saying, I'm already been approved for exercise. My cardiologist knows about this. And so, even if you're just doing like range of motion exercises and your rehab exercises aren't necessarily things that are getting their heart rate and blood pressure up a lot, you probably still are having them warm up and doing those things, right? So you got to be careful there as well. And this 2.5 miles per hour, 12% grade, it's not nothing, but it's not very strenuous. We're not in the 3rd, 4th, 5th stages of the Bruce, right? So taking into consideration the heart rate and the blood pressure there, calculating rate pressure product, and then prescribing a warm-up or whatever your exercise plan is, making sure that you are going to keep their heart rate and blood pressure below where their rate pressure product would cause them to begin having these symptoms. The other thing is, being around PT clinics, I'm not a PT, but like being around them and understanding how they work, you're not getting blood pressure all the time. You're not even taking heart rate all the time after every exercise, right? But if a patient came to you and had this situation, this might actually trigger you to think, maybe I should be taking heart rate and blood pressure a little bit more frequently throughout their exercise program. Okay, so here's just some information that you can share and kind of walk through that case study with, right? So we want to keep exercise at least 10% below that rate pressure product of 20,540. And you also know the workload. So the workload around 7 METs for stage 2, around 24.5 mLs per kg per minute. And so if we actually do 10% of that, we're probably going to keep her around 22 mLs per kg per minute. So they're not experiencing those symptoms. So this is fairly easy to calculate and then look at the intensity of maybe the bike you're putting them on, or being very clear with instructions, like don't go above this level with the patients is helpful. And then checking those measures regularly. The other thing we look at is blood pressure recovery. Just like heart rate recovery, we want our blood pressure to come back down to normal. We usually see declines to baseline within 5 to 6 minutes, but a delay in systolic blood pressure return to pre-exercise levels actually represents an abnormal response in that if it doesn't occur in that period of time. We also look at 3-minute recovery systolic blood pressure. And with this, we want the ratio of the 3-minute recovery systolic blood pressure over the peak systolic blood pressure to be less than 0.9. So anything greater than 0.9 is considered abnormal. But let's say that peak systolic blood pressure was not obtained because someone was running during the test. You can do 3-minute recovery systolic blood pressure over 1-minute recovery systolic blood pressure. And if that is used instead of peak, anything greater than 1.0 is considered abnormal. Okay, so either one we have measures on, and then what would be normal or abnormal responses. So putting all of those measurements together, we actually can look at things, okay, so we're seeing this with heart rate, we're seeing this with blood pressure, we're seeing this with ventilation, and we can start to puzzle piece like, what does that mean, right? So if someone's deconditioned, they're going to have a low to normal peak VO2, but someone with a heart disease. So how do we know if it's deconditioning or heart disease? Well, there's other factors at play, right? So deconditioning, we have low to normal peak VO2, low anaerobic threshold, but there's absence of any other abnormal responses. So they're not necessarily having chest pain. They're not having dizziness, right? With obesity, we see increased VO2 to workload slope. We see that VO2 peak is usually less than predicted, and absolute VO2 is normal or actually greater than predicted. So before we put body weight into the equation, we talked about how VO2 is associated with your full body size. So someone with a larger body will have a higher VO2. And it's really the relative VO2, once we divide that number by their weight in kilograms, that gives us a better indication of fitness level, and allows us to compare folks to one another when it comes to fitness. Cardiac is going to be O2 pulse less than 80% predicted, potentially having chronotropic incompetence, poor heart rate recovery, potentially symptoms like angina, or we're seeing things on the electrocardiogram that are not good, like ST depression and or ST elevation. So ST depression is cardiac ischemia. And when it's 1 millimeter in multiple leads, that's an indication that we stop the test and there's ischemia going, or the heart's ischemic. Or when it's 2 millimeters just in one lead, we'll stop the test. And obviously, you got to be mindful of artifact and things like that. But usually, definitely it's more clear when you're seeing it in multiple leads. But if artifact is coming in, making sure like you're looking at the patient, that's really a good thing to do. Are they experiencing any symptoms? If they're truly having 2 millimeters of 2 millimeters depression, they're going to be having symptoms too. So you're looking at the patient and you're kind of deciding, is this artifact, is it starting to level off or is it not? Those are all things to consider. Low VO2 max, low anaerobic threshold in these cardiac patients, and increased ventilatory efficiency. That's going to be different than our pulmonary limitations. What we're seeing with pulmonary folks is going to be peak exercise respiratory rate above 50 per minute. So they're really having a hard time doing that deep breathing, and it's really, really a laborious process for them. Oxygen desats on their pulse oximetry, and abnormal exercise flow volume loops, which we didn't really get into, but it's really reflecting of ventilation to our gases that we're looking at. Muscular disease, submaximal cardiac and respiratory responses, anaerobic threshold less than 40% peak VO2, elevated lactate. That's a big one, even at submaximal levels. So you can, as I was mentioning, you just kind of piece these things together to kind of think about what is the issue that this patient is dealing with, because they are going to be different. Just another way to look at it, brings in a couple other diseases and even separates out interstitial lung disease from COPD, heart failure from looking at heart failure compared to just cardiac limitations on the past slide. So another way to look at it. Okay. This is like a summary of really what should be taken before, during, and after each exercise test, looking at the electrocardiogram that the participant will be hooked up to, heart rate, blood pressure, any signs and symptoms that's being monitored out like continuously throughout the test. And then their rating of perceived exertion. Rating of perceived exertion is a great one, and it's actually used in cardiac rehab a lot, where we're asking the patient, how hard do you feel like you're working? These patients come in every day with different levels of stress, different levels of fatigue. So one day a 12 might feel like a 12 on that scale, and another day a 10 might feel like a 12, right? So if they're telling us, if we say we want you to stay at a 12, that workload can change, but as long as they're within that comfort zone, that's something that's important for that population. So rating of perceived exertion is taken often in exercise, and definitely on the exercise test, it's helpful to see where they're at when they're at that 12 or 10, to then write an exercise program appropriately around that same level. When to stop a test. So any symptoms like angina, when systolic blood pressure drops, and obviously when it's a trained technician. So if you haven't done blood pressure on on a treadmill, when someone's exercising on a treadmill, it can be really difficult. And so sometimes, as we're getting started and learning this, if you kind of expect a drop or you hear a drop, you might want to confirm. Obviously, you're looking at the patient to see if they're having any signs, any symptoms, but you might have someone else step in and confirm that it truly is a drop. Excessive rise in blood pressure, shortness of breath, signs of poor perfusion. So again, looking at the patient, are they, having poor coloring? Do they show signs of lightheadedness and dizziness? Failure of heart rate to increase with increased exercise intensity, any notable changes in heart rhythm. So if we're seeing some arrhythmia that like multiple PVCs that are coming more frequently, we might stop the test. And it really does depend on the clinic too. Like first, what's the purpose of the test, as well as are we in a clinic that has medications available if something were to happen, as well as maybe a physician on site. And if the patient or participant wants to stop the test, any faulty testing equipment, those are all important factors too. So all of this to say, with writing an exercise program, using the data that you obtain from the exercise test to write a really appropriate and beneficial program for that patient, participant, athlete, whoever it is. In this specific study, we're going to be talking about normal, healthy adults, right, that have risk factors for disease. And in a baseline study where we took individuals' cardiorespiratory fitness or VO2 max, we saw that over time, individuals with higher VO2 max, they had higher increased survival, whereas those with lower VO2 max had increased risk of premature mortality of all cause, cardiovascular disease, and cancer. But what we also see with the literature is that improvements in fitness are associated with survival. So just because someone comes in at baseline with low fitness doesn't mean that we can't get them on an exercise program and get them to be active, right? A lot of people that you guys are going to be seeing are going to be people that haven't been active for a while and potentially haven't been because of some musculoskeletal issue they've been having. But now we're treating that, and we're also in the same time potentially helping them understand the benefits of exercise, allowing them to be pain-free so they can potentially pain-free go exercise, right? And so with that, we're going to see improvements in fitness and therefore survival benefits. And we see this in normal, healthy individuals. We see it in those with cardiovascular disease. So those that are already diagnosed with disease, if we can get them into cardiac rehab or some type of exercise program that is safe for them, and they can improve their fitness, they have an increased chance of survival. These two studies here, Martin et al. And Van Hees et al., they showed that, an exercise training program of about 3 months, we saw in many folks improvements from their VO2 max test or their cardiopulmonary exercise test from baseline to follow up, or maybe they just did an indirect method as the Martin study did. And every 1 MET increase in exercise capacity or cardiorespiratory fitness, there was a 13% reduction in premature mortality in these cardiovascular folks. And Van Hees, which measured it on a cardiopulmonary exercise test, less people, but we saw a 1 MET increase corresponding to a 7% reduction in premature mortality. So pretty cool. And what this study here took is actually looked at data and of normal healthy adults, cardiopulmonary exercise testing around 3 to 8 months between tests. Those that followed 75% of their written exercise program, they had a reduction in risk of premature mortality, and that reduction actually mirrored a similar risk level as if they were fit to begin with. So if the blue line is low fit always, and you stayed low fit, the yellow line is fit, and then the green line is low fit, but you became fit after a few months of your exercise program, you no longer have risk. Your risk level is the same as if you were fit to begin with. Okay, so a change in cardiorespiratory fitness in this study was around 5 mLs per kg per minute. 72% that were low fit became fit by their second test. Those that were unfit and remained unfit had a 87% or twofold higher risk of mortality than the unfit to fit and fit to fit folks. Right? So we just got to get people active. And what's really cool and what you'll see with the aerobic center longitudinal study too, is that you don't necessarily need to go like from doing nothing to running marathons, right? We just need to get you on like a brisk walking program, get you moving, right? Having these patients come see PTs who are going to give them an exercise program so they can do their activities of living, feel better, and then continue on with lifestyle exercise. That's great. That's what we need. And again, the study, 25% lower risk per 1 MET increase in VO2 peak post-training. That's huge. I also really like this. This analysis is a Wald chi-square test of association. And what it was showing was looking at, okay, which one's more impactful when we think about risk? Is it that first baseline test or is it the second test? And it showed that VO2 peak measured at that second test was found to be a stronger predictor of all-cause mortality compared to VO2 peak measured at the first test. And this is also really great to hear because we as a population, it's like 28% of our population actually meets the American College of Sports Medicine guidelines for aerobic and strength training, right? There are a lot of people out there that are sedentary. And so some people are under the mindset, like, if I can't do anything, I'm not going to, if I can't meet the guidelines, I'm not going to do anything at all. I've literally given up on my exercise program for years now. Why start? It's going to be so hard to get back into it. I mean, these are things we hear all the time, right? And so here is the message. Like, it's okay that you're unfit today. We just need to get you fit. And that's going to be a stronger predictor of your health going forward. So just a summary of that study, results showed a significant inverse relationship between the change in cardiorespiratory fitness and all-cause mortality risk. And really, you guys, this is sort of a little bit dated now, 2016, which seems crazy, but American Heart Association put out a scientific statement that said cardiorespiratory fitness should be considered a vital sign. And they said, like, it doesn't matter how you measure it. Do it by the sit to stand. Do it by a non-exercise prediction equation. Just do it so you are having this information and can encourage individuals from that information to participate in exercise training program to improve fitness. And really getting at the low fit individuals, those are the people we want to target to try to get them out of that unfit group and into the fit group. So if we think about all of this and then potentially like how does this relate to what you all are going to be doing? I think it's important to think about different patients that you might be seeing, right? So if we think about potentially a classic example of someone coming into PT, knee OA, right? The referral might also include something like VO2 max, right? These people don't just have knee OA. There's other things going on. Maybe they do, but for a lot of folks, they have high cholesterol, hypertension, potentially they already have pre-existing disease, maybe a metabolic, maybe cardiovascular. And so maybe they're already coming in with a measurement of cardiorespiratory fitness. Maybe it's something you can do through a 6-minute walk test. But if you're finding out that they have low aerobic capacity and you're calculating then from that, what's their max MET levels? How can I use that to then inform what I should be prescribing, right? So if they come in and their maximal MET level is their maximal VO2 is 18 mLs per kg per minute, which is around 5 METs. Okay, well, now I've got to think about how is that limiting and impacting the knee OA, right? If it's 5 METs, what am I doing to even get them, in my rehab program for them? That's going to be not above that anaerobic threshold where they're feeling sore and potentially not come back because they're not feeling great after leaving, right? So those are things to consider and really how this could be an important measurement in your own practice. So thanks, and we'll talk soon. I'm going to be recording a lecture or recording the cardiopulmonary exercise test with some folks from your class this weekend. So make sure to watch that so you know how to do it. And I'm available for questions, comments, any of that. So feel free to reach out. Thanks.